All right. Thank you, Kirsten, for that introduction. And let's go ahead and get started. Today, we're going to talk about water. What is the risk? Funding for this presentation was provided by the Kentucky Department for Public Health. Content includes discussion of unlabeled use of products. Presenter has no financial interest or other relationships with manufacturers of products. No commercial support was provided for this educational activity. So what are our objectives for today? We're going to describe the impact of Legionnaires' disease on the healthcare system, state why a water infection control risk assessment is needed, and conduct a water infection control risk assessment. So what is the impact? We know that over 40,000 annual hospitalizations occur for primary waterborne diseases. So these include things like Giardiasis, cryptosporidiosis, and Legionnaires' disease, among others. It costs $970 million annually, with at least $430 million in Medicare and Medicaid cost patients. And Legionnaires' disease and non-tuberculosis mycobacterium infections have the highest cost. The use of filtration and disinfection to make clean water available has been recognized as one of the greatest U.S. public health achievements of the 20th century. It's been credited with an estimation of about 50% of reduction in mortality in major cities, and nearly 2/3 of decrease in child mortality observed in the early 1900s. We have processes in place now to ensure that the water that we consume is safe and clean and has been through all the processes, but we also have to recognize that we are providing care to individuals with different levels of overall health, and we are dealing with very complex water systems and patient care equipment. Some may say that Legionella is not an issue in the United States, but this graph from the CDC would suggest otherwise. You can see here that there is a continued upward trend in cases of Legionella since it became a reportable disease. There was a decrease during the time period of the pandemic, though it is not clear if that was a true decrease or a result of decreased reporting. Either way, it's trending back up.
So I wanted to look at a couple of cases of outbreaks that have occurred that have impacted healthcare systems, because many times we say that's not going to happen to us. And that is the intent of everyone, is that it won't happen to them. But we have to be sure that we are aware of what's going on. So this is actually an epi review that was done by Smith et al. And they they investigated the increase of Legionnaires' disease in Flint, Michigan. This is a case that many of us have probably heard about, as it made national news secondary to the impact that the water change had on the community of Flint, Michigan as a whole. So in this review, we knew that in April of 2014, the water source in Flint, Michigan, changed from the Detroit Water and Sewerage Department to the Flint River Water Company. The water from the Flint River water was treated and distributed without a corrosion inhibitor. And shortly after the change in the water, residents started to note issues: color of the water, odor, the taste, and many residents actually ended up with skin rashes. Ultimately, there was an increased lead levels noted in children living in Flint, and outbreaks of Legionella were actually identified. In October 2015, so a little over a year after the transition, a state of emergency was declared in Flint, which again, I think many of us heard about, and a change was made back to the Detroit Water and Sewerage Department. But the real question was, what were the sources of these outbreaks of Legionnaires' disease? And so, as I said, Smith et al. Did an epi review of the outbreak. They found that Legionnaires' disease cases were 3.59 times higher than expected in 2014 and 3.67 times higher than expected in 2015. 86 patients met the case definition. And hospital A exposure was reported for 42 cases. So 49% of the overall cases had some exposure to hospital A. Unfortunately, even after excluding for hospital A cases, the Legionnaires disease was still higher than other Michigan counties, indicating that there were other sources of exposure. And ultimately, they found there was a strong evidence for hospital A associated outbreak in both 14 and 15. And that there was other issues related to contact with living in Flint, Michigan, as well as cooling systems. They did look and see there was whole genome sequencing done that showed isolates from cases exposed to hospital A and the hospital plumbing, which unfortunately was also growing Legionella, were reported to be similar. And so while yes, there were other potential causes or sources, the main source at the time was noted to be the hospital. And so this here shows an epi curve of cases in Genesee County, which is where the city of Flint, Michigan is actually located, in 2014 through 2015 by month. And so I want to draw your attention to the top graph. And this shows the cases with exposure to hospital A, residential exposure to Flint water, and no exposure to Flint to hospital A or Flint at all. And you can see there the blue is resident on water, the red is hospital exposure, the blue and red together is those individuals that had both, and then the 9 are the gray boxes, and you can see that the majority had contact with one or both. B actually shows the cases with and without exposure to hospital A. And so the arrows represent dates that the Legionella control interventions and the plumbing system of hospital A were put into place. So hospital A hyperchlorination events occurred during that solid line arrow down there. So you can see there were quite a few in the beginning of 2014. They did a hyperchlorination event. It kind of went away. It came back up. In which case they did a superheating, or no, excuse me, yes, a superheating and hyperchlorination, which is the dotted lines, and then they did monochloramination, which is those dashed lines. And then you can see down there at the bottom, cases with and without residents on Flint water. And those arrows indicate when the transition occurred from Detroit to Flint water, which is the solid line there at the beginning, and when they switched back to Detroit water, which was this dashed line here. And so ultimately, while there was a lot of issues going on with the water in that county and particularly in Flint, you can see that there really was pretty significant evidence associated with a hospital acquired or a hospital associated outbreak. So some may say that the outbreak was associated with the change of the municipal water, and that had to have been the cause. However, if you Google Legionnaires disease outbreak, you'll find that they continue to occur. This is a case that was reported on NBC News on September the 5th, 2024. And reportedly, it says that 20 patients were hospitalized, 10 tested positive, 3 patients have died. And directly from the article, it says some water samples at the Purigene Senior Living Facility have tested positive for Legionella, and further testing is being done. I suspect that is not the publicity that any facility wants. And obviously, patients were severely negatively impacted by this, and some did not survive. And we know that this is not just an issue with our HVAC or cooling towers. These opportunistic pathogens can form biofilms within your water system and impact patients through other areas of care, such as showers and ice machines. Interestingly, the CDC just released an MMWR on the 3rd of October, reporting an outbreak of burkholderia in both California and Colorado associated with ice machines. This outbreak has thus far impacted 46 patients And while the investigation is ongoing, the ultimate recommendation is to limit the growth and spread of water-related pathogens in water systems, including ice machines. Health facilities should devise and implement a water management program and identify all potential pathways of water transmission to minimize patient risk for infection. So that leads us into why do a water infection control risk assessment? So we've talked about the risk that exists and the impact these opportunistic pathogens have. And so now we need to talk about the water infection control risk assessment, or most commonly known as the WICRA. And this is really what's going to drive your plan. And so many times we kind of get a little bit nervous about doing a risk assessment, but what we have to recognize is that we do risk assessments all the time in our regular lives. And so one example is if you're going to take a vacation to the beach, right? There's different times that you can or should or don't take vacations to different areas of the country. But you need to know the risk and you assess for that. For example, if I'm going to go to the beach in October in the United States, there is a risk for hurricanes, as we are experiencing now. It's not to suggest that you don't go to the beach, but it is to suggest that you probably do some type of risk assessment. You probably want to make sure that you're doing what needs to be done. And then assessing that situation. It's not, I know that I'm going during hurricane season, but never again checking the weather. So the point of this risk assessment is to identify areas of opportunity. What are those things within your facility that could be a potential risk to your patients or to your workers? To develop your management plan, what are you going to do about it? To develop what needs to be monitored, how are you going to look at it? And when and how the monitoring is completed. Saying I'm going to monitor for something and then not having a plan for how you're going to do it is not going to help you. It's also very important when doing a risk assessment that you're very honest with yourself and the facility. So again, saying that I have a plan or I've done an assessment and not truly looking at what are my risks really sets you up for opportunities for adverse events to occur. So what is a WICRA? We know it's a tool used to identify the risk within your water system. You need to evaluate the sources of water. Is the water coming from your municipal supply? Is the water coming from some RO? Is the water sterile water? Where is the water coming from? What are the potential modes of transmission? What does that look like? Is the mode of transmission through aerosolization, droplets, ingestion? What type of patients do you provide care to? Are they residents in a long-term care facility? Are they individuals receiving a bone marrow transplant? Are they anybody in between that group? And what are the exposure opportunities? What are the patients doing, or what are you doing as it relates to providing care to the patient that increases or decreases their exposure opportunities? Interestingly, with the Burkholderia outbreak that has occurred with ice machines, not only was it an ingestion issue, but individuals would have their ice packs refilled after surgery. That is a relatively common practice. And so they found that they had Burkholderia and abdominal wounds because they were filling ice packs with contaminated water, and those packs may leak. And then how prepared are you for these events to occur? What are you going to do? So when do you do the WICRA? You want to initially really recognize that this should be a fluid document, okay? So when you initially develop your water management program, you should absolutely have your WICRA. Your water management plan may have prescribed times that the WICRA should be updated annually, every 6 months, for example. But that is not the only time that the WICRA should be reviewed. You can't just leave it and let it be and think that that is enough. You need to think about, what about when new equipment is brought into the building that requires the use of water? This can be something like ice machines, fluid warmers, something of the like. What about a change in the facility structure? Remediation, right? You have to go in and fix plumbing for some reason. You're going to do an addition to the facility. What impact does that have on your water system, and what needs to be done to mitigate the risk? You may say in your risk assessment that when you get into the building walls again, you're going to maybe remove some of those dead ends. But if you don't go back to your WICRA, then you really don't have what drives your plan. And so I go back to, if I'm traveling to the beach during hurricane season and I never check the water or the weather, I might travel during a time that is maybe not the best choice for me. Who is involved in conducting the water infection control risk assessment? So I can't stress enough that this is a multidisciplinary group. We all come to the table with a different skill set and a different frame of reference of which we are going to look at things. And so it's important that all the key players are involved in the process. For example, the infection preventionist may recommend one thing that is absolutely not possible from a water source perspective that the facility engineers would potentially know. So having infection prevention, our facility engineering department, our environmental services colleagues, safety officers, quality groups, it's just imperative that you have the key players, individuals that are actually in the units that you are looking at, so that you understand what is their practice and what are they actually doing. So what are things that you need to consider? This is a beautiful document that is a screenshot, and the references for this particular slide deck is at the end, so you can go straight to this, but this is directly from the CDC. And they list all those things that you need to consider. Now, we have to recognize that this is clearly not an all-inclusive list. There are other items that your facility may have that could be potential water sources, but this is absolutely a good starting point to help you understand what you need to look at. This is not a document that can be created in a 1-hour sit-down meeting. This is a document that requires going to the locations, looking around, talking to people, seeing how they're using water and what their process is within that particular space. So a couple of things to consider, again, are what are those water sources? You can see there's quite a few water sources, and it's not all just coming from the sinks or the showers. They've listed ventilators, they've listed ice machines, endoscopes, all kinds of things have contact with water. Thinking about the modes of transmission, this goes everything from, did the individual use that water for showering? Are they ingesting it? Can it be aerosolized? What is the mode that the water can be transmitted in those particular locations? Thinking about patient susceptibility. So this goes from everything from our high-risk patients, so BMT patients, like I said a minute ago, all the way to administrative office areas. And so I point that out because there are some areas that we think we don't need to look at, right? We're not providing patient care in an administrative office. However, if there's Legionella in the water and it's aerosolized, there is risk there. Risk not only to the individual that is in that space, but also to our patients. So it's any water source throughout that entire facility, not just the locations that one would typically think 100% provide care to patients. Then we have to think about how frequently are they exposed to that particular risk. Are they exposed a lot? Or are they hardly ever exposed because patients don't ever go into that area? It doesn't mean we don't do an assessment of it if they never go in that area. We just recognize that the patient exposure may be minimal at best. And then what is your current preparedness? And I think this is the area that we have to be most honest with ourselves. I want to acknowledge that poor preparedness is some policies and procedures or limited policies and procedures, but having a policy and procedure and not having mitigation strategies isn't going to help you. So the question becomes, how do you perform a risk assessment? And so that's what we're going to talk about here for the next few minutes. So this, again, is the example directly from the CDC site. They have a facility name, they have an assessment location. So in this scenario, it was the burn unit. They have who performed the risk assessment, what was their role on the team. And then they've gone through and looked at individual locations within the facility. What are sources of the water? What were some of the indirect contact that they could have had? And then what were some of the patient susceptibility exposure preparedness? In this scenario, you take those highest to lowest and you multiply that across to develop your total risk score. And then they put some comments to what are some things that they could do to decrease that risk. So you'll notice it says install splash guards, QI for sink hygiene, and flushing, right? So while those are comments of suggestions, one could argue that there needs to be a little bit more behind that. Flushing when, by whom, with what, right? So this is to say this is my risk. This is the beginning of developing that plan. So what we're going to do now is go through and look at some scenarios. I will show you all some pictures, and then if you can just put into the chat there what you think would be some of the maybe the risk or some questions that you would ask about each of these scenarios. So I believe everyone should have access to put comments in the chat. All right. Apologies, the slide didn't change. Okay. This is an image. So this is an intensive care unit. It's equipped to care for adult patients requiring complex medical support, including those on ventilators, undergoing dialysis, or recovering from solid organ transplant. This layout prioritizes effective patient care, safety, accessibility, and addressing the unique needs of critical care patients. So looking at this particular room, what would you say are some of the areas that would need to be considered for risk associated with water in this particular room? What are some of the questions that you would ask? All right. So we've got quite a few questions coming in. One of the things that people have commented about is the sink. So the sink is very close to the head of the bed. And what would be needed by the sink is likely a splash guard, right? Because one thing that would be of concern, right, is we've got this sink. It's a beautiful sink. It's a beautiful room, right? But there's not really a splash guard there to prevent me from putting patient care items within that space. And so there is a potential risk that all of my patient care items are going to be wet or get contaminated within that splash space. There's the question about the plant. So is that a live plant or not a live plant? There's a heater cooler by the window. What's the maintenance for that air conditioning unit there by the window? What are water sources associated with that? There was some comments about what about hookup for dialysis? If the sink has an aerator, what is the risk there? Obviously, there's the risk of aerosolization, particularly with the sink this close to the patient's head of the bed. And so one could say, if we look at this particular room, we know we have an ICU patient. So we have patients with high susceptibility. So they would probably be put as a 4. Patient exposure, which we know would be the frequency that they would potentially be exposed to these water. It's an intensive care unit room. It's going to be probably pretty high. Preparedness, we don't entirely know, but we do know that there's not splash guards. So if we look at practice across time, it seems pretty likely that people are going to encroach onto the sink. What is the process for making sure that the aerator, if it exists, is changed out on a regular basis? And so maybe the preparedness is super good and they've got a great plan, or maybe it's not, and we need to really look and see what our opportunities are that could exist. All right, let's look at the next image here. So this is a medical surgical unit. It is dedicated to caring for pediatric patients ranging from neonate to 18 years of age. This design focuses on providing patient care and amenities for young patients in the unit. I bring up age because infants typically are not taking a shower. And so what would you say within this space could be some of the risk associated with the bathroom? All right. So a couple of comments came in. One of the main things, or one of the common themes in the comments, was that there's a loop there in the shower head, or excuse me, in the shower hose. This is not entirely uncommon. And if they drop that loop, the shower head is actually going to be on the floor. So some would say, well, just drop the loop and let the shower head hang. That would not work, at least with this particular picture. One question was, how frequently is the shower run if it's not used, right? So not all patients are able to get up and just shower when they're in the hospital. So it might be some period of time before the shower is ever used. And so that can be a huge huge risk. The toilet does not have a toilet seat cover. So, you can create aerosolized from flushing. There are items, multi-use items there in the back, which may be fine as long as there is a process for making sure that that area is cleaned. There are also supplies above the commode, so you can aerosolize and then have indirect or direct exposure. It's really unclear what the usage frequency is. So again, understanding flushing of those spaces. So if I were to go through and do a WICRA for that particular image, patient susceptibility, it's a med-surg patient floor. So it probably wouldn't be as high, obviously, as our ICU patients. So potentially that'd be moderate patient susceptibility, but the patient exposure could be pretty high. Potentially, if I have infants that go into that room the majority of the time and I have no flushing process for my shower, and then a teenager is admitted, they're going to get a pretty high dose exposure potentially, especially if that loop exists. And so current preparedness, not entirely sure, but it could be pretty poor since they're not going to really be able to decrease that loop easily without doing some significant mitigation in that space. So the next picture we have here, so this is a long-term care facility dedicated to provide care to residents with multiple health issues. This decorative fountain is located in the atrium, which serves as a popular gathering spot for residents. So what are some of the opportunities, or if we were going to do a risk assessment for this, what would be some of the things that we would have to consider? Aside from completely removing the fountain. All right. So it seemed, other than people commenting that the fountain in general is a nightmare and just needs to go, there was questions about the floor scrubber. What is that? I didn't like that at first, but then I recognize that that's another source of water that I'm not sure that people consider could be an issue, and what's your process for ensuring that those are maintained correctly. Um, One suggestion is getting rid of it and using decorative glass and pebbles. And so all of these are great potential suggestions or mitigation strategies. When we look at it, patient susceptibility, they're probably not our highest risk patients, but they would be at a minimum are moderate. Patient exposure, it is behind a glass wall. So presumably, you know, maybe they can't come up to it, though there is quite a bit of space. So I suspect that they probably can. So they would have probably pretty direct exposure to aerosols. And if that's the case, one could argue that the current preparedness is pretty low because there's no barrier there to prevent that aerosolization from occurring. There's also questions about the plant life. What's the frequency of testing? All of those things would go into the determination of your current preparedness. Again, me saying we test it does not mean that I am prepared, because it only means I'm prepared if I test it, I look at the results, I have a good mitigation strategy, I do regular maintenance, cleaning, and all those things to ensure that testing is done and effective. So I'm going to hand it off now to Holly, who is going to talk to you guys more about the infection control risk assessment and the ICARs that are done at the facilities. And this really goes nicely into how you can really look at those risks that are in your facilities and determine what needs to be part of your WICRA and your plan. So I am going to stop my share now.
All right. Thank you so much, Julia. Just a intro for Holly. Holly Swift is with the Kentucky Department of Public Health. She is the Region 3 infection preventionist, and she is an RN with her CIC and has worked as an infection preventionist for the past 9 years. So Holly, I think you're good to go ahead and share your screen.
All right. Can y'all hear me okay?
We can.
All right. I'm happy to be here today. Again, my name is Holly Swift, and as Kristen just stated, I am the Region 3 infection preventionist for the Kentucky Department for Public Health. Julia did a fantastic job at describing why it's important that facilities have a water management program and how to do a WICRA. So what I'm going to talk to you about today is how to assess your water management program once you have put that into place. So I live in a part of Kentucky that doesn't have the best internet access. So I'm going to be talking to you about CDC's infection control risk assessment. And specifically, I'm going to be talking to you about Module 11. So the key points for today's presentation or the objectives is to talk about the ICAR at a glance, to talk about Module 11 specifically, Part A and Part B, and to discuss the biggest areas for opportunity. Next slide. So the ICAR, what is the ICAR? So an ICAR is a tool developed by the CDC that is used to systematically assess a healthcare facility's infection prevention and control practices to help guide quality improvement activities. It is intended for use in acute care, long-term care, and outpatient settings. It is important to note that it is not intended for the use in outpatient hemodialysis clinics. While we are focusing on CDC's Module 11 today, it should be noted that CDC has developed a demographics form and 10 additional modules to assist with assessing the foundational domains of infection prevention policies and practices. These cover topics such as hand hygiene, environmental services, transmission-based precautions, high-level disinfection, healthcare laundry, point-of-care blood testing, antimicrobial stewardship, wound care, infection prevention and control auditing, and injection safety. Next slide. And Julia, I don't think that you have the most up-to-date presentation.
Okay. We will just work from this and we can send out the correct one, should be on the website.
Okay. This is going to throw me off a little bit, so I'll do the best that I can do. So Module 11 does have two parts. It has a Part A, which is the interview section of the module. So this section is intended to aid in the review of a healthcare facility's infection risk posed by water exposures and related policies. It is important that this interview includes all of the key players, and especially the person that is in charge of plant operations or facilities management. Part B of the water exposure is the observation section. So it is a corresponding component to guide observations about water exposure risk. This portion of the tool is intended for direct observations of water exposure practices. Ideally, at least 3 patient care areas are observed. Next slide. So these are the topics that are addressed in Module 11, Part A. So on my other presentation, each slide would go into more detail about each one of these topics. So I'm just going to kind of wing it from here. So the first topic is the water management program. Does your facility have a water management plan? Have you completed a WICRA, which is what Julia had talked about in the first presentation? If you have, when was the last time that WICRA was completed? Were there any issues that were identified at that time, and what mitigation efforts were implemented? Water-associated pathogens. Does your facility have a surveillance process for water-associated pathogens, such as Legionella, Burkholderia, Stenotrophomonas, etc.? So you want to make sure that you do have those in your surveillance plan. What measures has your facility implemented to reduce the risk from water? Do you have patient care supplies outside of your splash zone, for example? Are your faucets offset from your drains? So those are some of the questions that are assessed under that topic. What about decorative water features in aquariums? Does your facility have any of these? I like to died a while ago when I saw that slide of the water fountain in Julia's presentation. I hadn't saw that before. So, those all give us anxiety as infection preventionists. So you want to make sure of areas like that. And if you do have any, what do you have written in your facility protocols to implement or to mitigate those risks? Patient care activities using water. Again, you want to look at your nebulizer treatments, your process for nebs. Are you rinsing with sterile water in between treatments? If you still use nebulizers that are for use on more than one patient, are you doing high-level disinfection and sterilization on those nebulizers? What about vulnerable populations? Do you have any units such as those transplant units? And this is an area that is especially important to look at. Do you have at your shower heads and your aerators? Do you have those? And if you do have those, what processes have you implemented to mitigate risk with those? Water disruption and water intrusion. You want to make sure your emergency preparedness plans addresses both of these topics. Next slide. All right, so again, that concludes the Part A of Module 11. And again, that is an interview section when you're really just sitting down with the key players in your facility and looking at your policies that you have in place. Part B is, to me, the most important part of the module, and that's where you're actually going to get up and you're going to go out in your facility and take a look around. So this is the observation section. And the 5 areas that the module guides you to look at are listed here on this slide. The ice machines, you're going to be looking to see, are they uncluttered? Are they clean? Are they free of insects? You're going to be looking at the medication preparation area. Are patient care supplies protected from splashing? Are those faucets offset from the drains? A lot of facilities have those faucets that are movable, and the OCD person may come by and straighten it up because they don't like it that it's kind of offset from the drain. But just make sure that you have educated staff that there is a reason why CDC recommends that those faucets are not hitting the drain directly. You're going to be looking at your soil utility rooms, specifically at the hoppers, and do they have covers? And you want to note if the doors remain closed when staff are flushing those hoppers. So that's very important. The communal shower rooms, items that you really want to look at there are your shower chairs. Are they constructed of non-porous material, and are they intact? What about the trolleys and the mats? Are they stored in a manner that allows for proper drying? And then lastly, the module 11 has you look at patient or resident rooms. Items that you're going to be looking at there are sink drains. Are they offset from the faucets again? Do the toilets have lids? Are patient care supplies protected from splashing? And you're going to be looking for any evidence of water intrusion. So the module 11 part B, it is best that you observe at least 3 patient care areas. But as we go into facilities, when I say we, the regional infection preventionist, we are also looking at locations other than this. So we're going to be looking everywhere. We're going to be looking even at your ancillary departments, your pharmacy, your lab, your radiology, even your medical offices, if you have any that are within or attached to your building, because these are all areas that sometimes are overlooked, but they also pose a potential risk to your patients and staff members and even visitors. Next slide. So as the regional infectionists are going out more and helping facilities to complete this Module 11 tool, we are seeing some areas that are commonly identified, and I have listed those here on this slide. So I would say probably the number one thing that I find when I go into facilities is patient care supplies that are being stored in the splash zones. And this is simply because there is a lack of storage. I think we all can relate to that. Also just a compliant thing. You can educate staff and let them know. Julia, I think your screen changed. Yeah, sorry. I just wanted to let you know. So that's okay. I lost my train of thought. Sorry. Storage in the splash zones. We can educate staff that you don't need to place patient care items within that splash zone, but somehow they always end their way back there. So some things that facilities have done is install those splash guards that Julia had discussed earlier in her presentation. Those are great, but just remember that if you install those, that those also have to have a plan for cleaning and disinfection. So just remember that. Something else that we see very often are patient care rooms that have been converted to office spaces. So again, this is, I think just over time, a lot of these facilities are old, buildings have been renovated, more staff are hired. So therefore, patient rooms are given to, let's just say, actually my office at my old facility was in an old patient care room. it was great because we had a restroom in our office. We use the toilet very often, and the sink, obviously, for hand washing. But those showers sometimes are often overlooked. And going back to the lack of storage, but we find that those showers are sometimes used for storage. So what that means is, how are you getting in there and how are you flushing those shower heads? More likely, they aren't getting flushed. And these office spaces that have been converted, sometimes they are not included in the facility flushing maintenance plan. So just keep that in mind. Some other water sources that we see often overlooked and not part of the facility flushing plan are the exterior faucets on the outside of the building, and then the decontamination showers in the emergency department and the lab. I have been in several facilities where that decontamination shower in the emergency department, again, is used for storage. So it's not likely that staff are going in there, removing all of those items and flushing that water source like they are the rest of their water sources throughout the facility. So keep that in mind. And then again, toilet and hopper covers, keep in mind that that is a CDC recommendation. Next slide, please. Okay, so here are just some resources that I included. And when Julia sends out the proper presentation, there's more resources than this. And I apologize for all the technical difficulties again. But this first resource here, this link will take you directly to the CDC iCar tool, where you can access all 11 modules that I talked about earlier. And this second link here takes you directly to module 11. And then there are two other links on the final presentation to the CDC toolkit and another CDC resource that is really great. So just keep that in mind and check those out. Next slide. All right, to conclude, just remember that CDC has developed these tools to help us easily assess our water management programs. They are user-friendly and have resources and recommendations already built in. And they're easily accessible to the public. Anybody can go on the CDC website and access these, download these for personal use. And then we also, I'm putting in a plug here for our program. There are 10 regional infection preventionists across the state that can come in and help you, can do this with you. And it's great to have a second set of eyes to see things that sometimes when we're the IP or a staff member, we get tunnel vision when we see it every day. If you don't know who your regional infection preventionist is, feel free to reach out to me and I can connect you with them. So I want to thank Julia and her team at the Kentucky Infection Prevention Training Center for putting this water management education series together. This presentation wouldn't have been possible without their assistance. Thank you so much for having me today, and thank you to the audience for showing up and showing your continued commitment to keeping Kentuckians safe in our healthcare system.
Thank you so much, Holly and Julia. This was a great webinar. So we do have a few questions. So first one I saw in the chat was, what about aquariums? Holly or Julia, would you like to tackle that one?
So I think, as with any of the water sources, you would want to treat an aquarium in the same capacity. So, I worked at a facility that had aquariums and the patients really liked them, right? And so the things that maybe aren't my favorite, water fountains and aquariums, are really quite relaxing for the patients or individuals that we are working to provide care to. So I wouldn't necessarily say get rid of aquariums, but I would suggest that making sure that you have a very strong plan for how that aquarium is managed. Many times that's a contracted activity. So somebody comes in and works on the tank. So having conversation with them and understanding what they are doing, and if it is following what would be industry standard for that type of product. So getting the results from their testing, knowing what they're doing to trust the water, how frequently are they changing the filter? I think the answer can't be we contract somebody to take care of our aquariums. I think the answer has to be somebody takes care of our aquarium. And this is how we are sure that what they are doing meets the industry standard or is able to be treated and tested and taken care of correctly. Nancy or Holly or anybody else on the panel, I don't know if you all would have a different response to that. The frequent thing is to say, just get rid of it. That's not always the easiest nor the best choice. So Nancy, I don't know if you've got particular answer to that otherwise.
The thing we're concerned about is aerosolization. So unless you have a real active fill going on or anything else that would generate an aerosol over the top of that tank, as long as it's back and it's protected and the patients can see it, I don't know that it's as much of a risk as many other things in the facility. So the person cleaning it, will always have to be careful when they drain or have to replace the water.
Mhm. Yeah, and I was going to add, if you have a fish tank or an aquarium, just make sure that your facility has written protocols in place that include the routine cleaning schedules and who that designated person is, of course.
Awesome. Thank you for those great answers. So we have one question in the Q&A. As an IP who has done a WICRA, where do I find what the results mean? My team and I have discussed the results. However, there is no table or key that indicates what the results mean as far as a risk level.
So I assume that you mean like the value, like if it's a high number or a low level, is that what you are referring to, like the value results? Just to clarify. I'm going to assume that that's the case. So I think that can be facility specific, right? So sometimes you can do a risk assessment and you add the numbers up and you say, if my number on my risk assessment is greater than 7, then that is considered high risk for me and I need to do something about it. On the CDC document, you multiply across, the higher the number, the higher the risk. So I think there isn't I know that the health department, the Kentucky Department for Public Health, our regional infection preventionist have, and Ruth Bellflower and her team have also created risk assessments, infection prevention risk assessments and the like. So it really just depends on how your facility wants to do it. Add it across, multiply them across. It's just if the higher, typically speaking, the higher number gets the higher attention. And you may not be able to do something for everything, but there are some things that are non-negotiables. So for example, even if it's a low risk, but it's a requirement by CMS or some other regulating group, then you need to have that in your plan as something that you acknowledge. And maybe in your plan, you say you've got a great process for it and you're not too much worried about it. But I've not seen, a direct, this has to, if it's got to be this number for you to do something. So that's really something that you determine with your facility. In my experience, we added them across and we said anything greater than 8 was a risk that we needed to have a plan for. If it was less than that, we felt like our plan was good, our strategies were in place. And while we didn't take our eye off of it or pretend like it didn't exist, we just maybe didn't have to have as robust of a process for it as some other things. So that's been the way that we have done them. Holly, I don't know if you've got something to add to that from an IP perspective on when you all do your risk assessments with your facilities, but I agree there isn't a set table that says if this value, then do something.
Yeah, I would agree with you, Julia. And I'm just speaking from my experience in acute care. When I would do these for my facility, we would just pick like the top 5 highest rated things and then make those a priority. Or, each facility may pick a different number. I'm just throwing that out there, but I agree with what you said.
All right, perfect. I do want to speak to this CE credit just before people have to hop off. We do have another question, I think, in the chat, but just in case anyone needs it, this is the QR code to obtain your CE certificate. You'll just either click the link or scan the QR code. There is a password. The password is water, all lowercase. And then for the next water management series throughout the rest of October, we'll also have one of these available. So if you have to jump off, that is fine, but we might be able to answer this one other question, I believe. You mentioned on the hoppers to make sure doors are closed when flushing. Does this go for patient room commodes as well? We do not have lids on our commodes in our patient rooms.
Do you have doors in your bathrooms?
Yes.
Yes. So I think that would be the other alternative, is to shut the door when you flush the toilet. The negative air that is required for bathrooms should pull any aerosols out.
So best practice would be to have covers, because the door would be, I guess, second best, but the covers, of course, you've got to close them before flushing, because whoever is flushing that commode is obviously in that room. So they're not beyond the door. So best practice is to have those covers, and that is a CDC recommendation.
Okay. Thank you so much. I think that answers all of the questions that we had in the chat and the Q&A. So thank you so much for coming. Did anyone have anything else to add?
Kirsten, I think that, so there was a comment about the survey says for Norton employees. So you should, I suspect that's for the CE. The CE is through ANCC, but we obtain it through Norton Healthcare. And so there should be a button that you can click that says other, so that you can put in your location. If there is not, then we will send to everyone an adjusted link, but you should be able to get the CE for everyone. It is not through Norton Healthcare proper, it's through ANCC.
Awesome. Thanks for clarifying, Julia. All right, we'll hang on here if anyone has any more questions, but other than that, I think we are done for the day. We'll see you guys back next Thursday, same time.